I will talk today about the diastolic assessment by echocardiography, and I will focus on the updated ASE guidelines in a summarized fashion. First, I like to start with the 2016 guidelines, which I liked, which were more straightforward. The 2016 guidelines focus on 4 features, and if you had 2 of them, then you have diastolic dysfunction with either normal or equivocal LA pressure. If you had 3 or more variables, then you have diastolic dysfunction with elevated left atrial pressure. Among those 4, the first one, reduced E prime, correlates purely with diastolic dysfunction and reduced myocardial recoil, whereas the second and the third one correlate with elevated LA pressure. E to E prime ratio is the single best correlate of high LA pressure. TR velocity over 2.8 meters per second, which corresponds to a systolic PA pressure more than 35 millimeter of mercury, also is another correlate of elevated LA pressure, although it may also be pure isolated primary pulmonary hypertension. You have the fourth feature here, which is LA volume index, which correlates with both diastolic dysfunction and more so high LA pressure to some degree. Now, this is my summary take on the 2025 ASE guidelines. Those guidelines may have complicated things, but they kept the same spirit. What they did, they insisted more on the 3 variables that I just described, and they insisted more on the fact that low E prime is a paramount feature to define impaired diastolic function, and on the fact that elevated E to E prime and or elevated TR velocity are paramount features to define elevated LA pressure. But they also added a bunch of other features. So they gave you more option to define diastolic dysfunction and elevated LA pressure. For example, they added pulmonary vein SND reversal or pulmonary vein abnormal A reversal or isovolemic relaxation time, LA reservoir strain, L lump, pulmonic regurgitation and diastolic velocity, which corresponds to PA diastolic pressure. And I personally like to add the LVH, severe LV mass elevation, which is used by the ESC guidelines in their HFpEF algorithm, which I think is important to incorporate along with the other parameters. So the 2025 ASE guidelines kept grossly the same spirit, but expanded the variables, and they grossly kept the same idea that a combination of 2 of those variables define diastolic dysfunction with normal or equivocal LA pressure, whereas a combo of 3 variables implies diastolic dysfunction with elevated left atrial pressure. And keep in mind that those parameters may also be used in heart failure with reduced EF. But in heart failure with reduced EF, the combination of variables is no longer used to define diastolic function because by definition, any systolic dysfunction has diastolic dysfunction. So in heart failure with reduced EF, this combination of variables is used to define whether LA pressure is elevated or not. So in sum, 2 variables imply diastolic dysfunction or systolic heart failure with normal or equivocal LA pressure, whereas 3 variables imply diastolic dysfunction or systolic heart failure with elevated LA pressure. And within that elevated LA pressure, we further subdivide it into grade 2 diastolic dysfunction if E to A ratio is less than 2, or grade 3 diastolic dysfunction, high LA pressure, if E to A ratio is 2 or more. And another important idea is that when you have 2 variables with normal or equivocal LA pressure at rest, if the patient has dyspnea, how do you know if that dyspnea is related to to that diastolic dysfunction or to another etiology, lung disease, anemia, deconditioning. So in those patients, you have to prove whether LA pressure rises with exercise or not in order to attribute dyspnea to diastolic dysfunction. And this is where we perform diastolic exercise stress testing to assess whether LA pressure rises with exercise or not, and we assess E to E prime and TR velocity in early recovery, as I will explain a little later. And to my summarized 2025 ASE algorithm, I would like to add a couple of ideas that are derived mostly from the older guidelines, but I find those very valuable. Whenever you have on the mitral inflow E to A ratio that is reversed less than 0.8, along with an E velocity that is an absolute value less than 50 centimeters per second, this implies normal left atrial pressure. Whether you have diastolic dysfunction or systolic dysfunction or you don't, you have normal LA pressure. In some cases, a reverse E to A ratio may reflect diastolic dysfunction, but it frequently does not. What it does reflect almost universally is normal LA pressure if, along with that reversal, you have an E velocity less than 50 centimeters per second. Another idea is that an E to A ratio that is over 2 in a patient over the age of 40 implies high left atrial pressure regardless of other parameter. E to A ratio may be normally over 2 in young individuals less than 30-40, but not in patients over 40, where it implies high left atrial pressure. So I like those two big parameters in that green box. Basically, in those cases, you can look at the mitral inflow and already know what is the LA pressure. Now, guidelines currently do not recommend that you use those in isolation. You should look at least at those three big parameters here. But when I see that on the mitral inflow, I kind of already know the answer, but I do still look at the other major parameters. And this is the actual algorithm from the 2025 ASC guidelines. I think it's a little bit confusing because even though they insist on the value of those three big parameters, they somehow require all three of them to define an elevated LA pressure. Yet, if you have only one of them with one of the less important features, you also end up with LA pressure elevation by that algorithm. So I think that algorithm is not reflective of their intent. They intend to give higher value for those parameters, yet if you dive into the details, it seems they are giving similar, if not higher value at times to the other parameters. Now I will describe each one of those parameters. Among those parameters, only one, E prime, correlates solely with the myocardial relaxation and with the LV diastolic recoil and is therefore reduced in LV dysfunction, whether systolic or diastolic, regardless of filling pressure. It correlates purely with LV myocardial recoil. And E prime is the mitral annular recoil in early diastole obtained on tissue Doppler analysis. Tissue Doppler analysis is analysis of the myocardial velocity as opposed to color Doppler, which analyzes blood velocity. So we do tissue Doppler and we measure medial E prime and lateral E prime. And there is a proper way of measuring those. In order to obtain a proper E prime, the pulse wave cursor should be placed within 5 millimeters of the septal or lateral leaflet insertion site at the ventricular side. And the pulse wave cursor should ideally be in line with the plane of annular motion, not at an angle, Otherwise, that E prime will be falsely reduced. And normally, medial E prime is lower than lateral E prime. Do you know why? This is because the medial annulus is anchored to the fibrous cytoskeleton of the heart. It's the same fibrous cytoskeleton that connects the posterior aspect of the aortic valve, the anterior mitral annulus, and the tricuspid valve. Part of that fibrous cytoskeleton is what we call mitro-aortic intervalvular fibrosa. So the medial mitral annulus is anchored to that fibrous cytoskeleton, whereas the lateral mitral annulus is muscular, so it recoils more than the medial annulus. One exception would be if you're acquiring the lateral E prime at an angle, whereas you're acquiring the medial E prime properly in line with it. In those cases, you will underestimate the lateral E prime, and it may appear to be lower than the medial E prime. In that case, I would discard that lateral E prime. I would not use it in my measurement. But another true exception wherein lateral E prime is lower than medial E prime is constrictive pericarditis, where the lateral annulus is tethered to the fibrous pericardium and medial E prime becomes more pronounced to compensate for the lack of diastolic recoil at the lateral side. Another advice, measure E prime at the tip of the solid portion. Do not extend your measurement to that blurry reverberation beneath it. Now, what are the normal values for medial and lateral E prime? It used to be said that the normal values for E prime are 10 and more laterally and 7 and more medially, but we now recognize that the cutoffs are actually 6 for the medial septal E prime and 7 for the lateral E prime, or maybe 8 for people between the ages of 40 and 65. So those are the numbers you need to remember. 6 for medial E prime and 7, 8 for lateral E prime, and 6.5 to 7 for the average medial and lateral E prime. Most of our patients are over the age of 40. Only for those patients less than 40, the old numbers apply. Lateral E prime should be over 10 normally, and medial E prime should be over 7 normally. Few more tips regarding E prime. Like I said, E prime is reduced in all cases of systolic or diastolic LV dysfunction. It's one of the cornerstones of the echocardiographic definition of LV dysfunction. However, there are some exceptions. E prime is not reduced in 4 potential cases of heart failure. 1, atrial fibrillation, which exaggerates E prime as you lose A prime. High output heart failure, mitral regurgitation with preserved LV function, and medial E prime will be preserved or exaggerated in constrictive pericarditis. Now, there are other cases where E prime is inherently reduced and the patient inherently has diastolic dysfunction. However, the exact E prime number doesn't correlate exactly with the degree of mitral elastic recoil. So the exact E prime number cannot be used into the E to E prime calculation. Those patients here have low E prime and they do have diastolic dysfunction, but the actual E prime number is not accurate. And those are the patients with some mitral annulus issues, such as prosthetic mitral valve, mitral ring, and severe mitral annular calcifications. Now I want to explain E velocity, then I will explain E to E prime ratio. So what is E velocity on the transmitral flow? E is the passive early diastolic filling of the LV, and it's driven by that gradient between LA pressure and LV pressure in early diastole. And this is what corresponds invasively to the E velocity. It's the gradient between LA pressure and LV pressure in early diastole. And what dictates that E velocity? 2 big parameters. One, E is dictated by LV relaxation. The slower that LV relaxation, the smaller the E wave. Compare this to that. The steeper and faster that LV relaxation, as in younger individual, the more you have LV dip and recoil in young, healthy individuals, the larger that E wave. But E wave is also more importantly determined by LA pressure. The higher that LA pressure and the V wave, as you see here, the higher the E velocity. The higher that V wave, the higher that E velocity. So E is determined by LA pressure predominantly and by LV relaxation. So if you have impaired LV relaxation with normal LA pressure, you will have a small E. If you have impaired LV function and relaxation in systolic or diastolic heart failure, but you have a big LA pressure with decompensated heart failure and overwhelmed LA compliance, you will have a big E wave. E velocity is also affected by heart rate and PR interval. The more tachycardic you are and the longer the PR interval, the smaller the E wave. But let's focus on those two parameters for simplicity. And we measure that transmitral flow typically on the apical 4-chamber view, preferably to the apical 2-chamber. So impaired LV relaxation reduces E velocity. That's why it used to be said in the past that E to A reversal less than 0.8 implies diastolic dysfunction. But this is obsolete now because that E to A reversal may simply be due to severe hypovolemia with low left-sided filling pressure, which may reduce E and E to A ratio even in the absence of a relaxation problem, even in relatively young individuals. Prolonged PR interval and sinus tachycardia reduce E and E to A ratio and may be associated with E to A fusion without any relaxation problem. That's why E to A reversal is no longer a significant important parameter of diastolic dysfunction. But like I said, a reverse E to A with an E less than 50 centimeters per second may be used to say you have normal LA pressure without necessarily implying diastolic dysfunction. On the other hand, high left atrial pressure, but also high pronounced LV elastic recoil and relaxation with a deep dip in early diastole may cause a big E wave in young individuals even without a high LA pressure. That's why I mentioned earlier that high E to A ratio more than 2 implies elevated left atrial pressure in patients over the age of 40, not in young individuals whose E to A ratio may be more than 2 because of pronounced LV recoil, not because of a high LA pressure. Now I will move on to define that E to E prime ratio. And I very much like this equation. I see a lot of fellows not knowing why E to E prime corresponds to LA pressure. E to E prime is actually the purest definition of LA pressure. And why is that? You can plug in this equation. We said that E is dependent on LA pressure and LV relaxation. So E is LA pressure times LV relaxation, whereas E prime is purely dependent on LV relaxation. So plug in this equation. E to E prime is equal to LA pressure times LV relaxation divided by LV relaxation. Therefore, E to E prime is equal to LA pressure. And in fact, the E to E prime ratio is approximately equal to LA pressure and the pulmonary capillary wedge pressure obtained invasively. So very important for you to understand that very simple equation. That's why E to E prime is the purest and best correlate of LA pressure. And what is the normal value for E to E prime? The septal E prime is smaller than lateral E prime. So the septal E to E prime is normally higher than the lateral E to E prime. So the cutoff for septal E to E prime is 15, whereas the cutoff for lateral E to E prime is 13. And the cutoff for average E to E prime is 14. And importantly, how do we define average E to E prime? Some people think that average E to E prime is medial E to E prime plus lateral E to E prime divided by 2. No. Average E to E prime is E divided by the average septal and lateral E prime. And it is abnormal when it is 14 or above. And we typically try to measure septal and lateral E prime and measure average E prime and average E to E prime. But in some cases where you can only obtain the proper medial or lateral E prime, then you use that one value in your assessment. For example, you may have a case where you get a proper medial E prime and your cursor is in line with the annular motion. However, your lateral E prime cursor is at an angle with the lateral annular motion and you underestimate the lateral E prime. In those cases, I may discard the lateral E prime and just use the medial one. Now I want to describe LA enlargement. LA enlargement is a landmark of increased LA pressure at some point, not necessarily right now. LA enlargement is highly sensitive in telling us that LA pressure has been elevated at some point, not necessarily right now. And those are the caveat of LA enlargement. LA may remain enlarged for some time after normalization of a previously elevated LA pressure. This is similar to deflating a balloon that has been inflated for some time. It remains wrinkled and larger than baseline for some time. So LA enlargement is highly common in diastolic dysfunction, but it doesn't always tell us that LA pressure is elevated right now. And occasionally, LA size may be normal in patients with diastolic dysfunction. It may be normal if diastolic dysfunction has been compensated for a very long time and that balloon of high LA pressure has shrunk with time, or it may be normal if diastolic dysfunction has been chronically mild and compensated with only episodic mild rises in LA pressure. Another caveat of LA enlargement is that even outside LV dysfunction, LA may be enlarged in persistent AFib, in morbid obesity with its high output state, and in mitral disease. But keep in mind that persistent AFib and morbid obesity are frequently associated with diastolic heart failure. So LA enlargement in those subsets may very well be increased LA pressure and diastolic heart failure, but it is less specific in those contexts. Now, how do we measure LA volume? We measure LA volume in two views, the apical 4-chamber and apical 2-chambers views. In end systole when LA is largest, and typically we have to open the LA well, avoid foreshortening. And frequently to open the left atrium well, we angle the probe a little anteriorly, and we frequently foreshorten the LV apex in order to open the LA well. A lot of time to open the apex well and avoid foreshortening the apex, we foreshorten the LA. But to open the LA well, we may foreshorten the LV apex. So we open the LA well and we measure its boundaries while excluding the left atrial appendage and the pulmonary veins. And the method we use is the method of discs, which is the same method we use to calculate the LV volume and the LVEF by the Simpson rule. And to measure the LA volume by the method of disc, we divide that LA into 15 to 20 slices of equal height, and each slice has a nearly homogeneous diameter, which differs between slices, but it's nearly the same at each level. And we assume that each slice is a disc, and we measure the volume of each slice, and we add those volumes. However, since it's not truly a disc, we have to measure that volume in the 4-chamber and in another view nearly orthogonal to it, the 2-chamber, and we average those measurements. And on any basic echocardiography, you should measure at least those 4 parameters routinely: E prime, E to E prime ratio, TR velocity, and LA volume index. Now I will discuss some other parameters that are useful and included in the expanded 2025 guidelines. And I will loop back to the mitral inflow and describe the E deceleration time. So I mentioned that when you have high left atrial pressure, you will have a big E wave, as you may see here. But in fact, that E is not only high, it's usually brief, because in those cases, it's not only that LA pressure is high, LV diastolic pressure is also high, and LV compliance is overwhelmed, so that the moment that LA pressure empties into the LV pressure will shoot up and flow will quickly cease in early diastole. So E wave is not only high, but it's also brief. And this is described by the E deceleration time, which is the time it takes the E velocity to fall from peak to zero. And it's typically less than 140 to 160 milliseconds in those decompensated heart failure with high LA pressure and overwhelmed LV diastolic pressure and compliance, which quickly equalize with the LA pressure. And that's why, by the way, in cases of decompensated systolic or diastolic heart failure, slowing the heart rate does not help, because you're not going to increase LV filling with a slow heart rate. You can only fill so much during that passive filling. E wave is very narrow. You benefit more from tachycardia to increase cardiac cycle and LA emptying into the LV. Now, in those patients with high filling pressures, you don't only get high and narrow E, you get something else called L lump. And L lump on the mitral inflow is a positive wave between E and A. Instead of having diastasis, which is cessation of flow between E and A, you will have continuous flow, which is what we call the L lump. And what explains the L lump in those patients? So those patients have high LA pressure and high LV diastolic pressure. The LA empties into the LV briefly and gives that brief E wave, and the flow ceases initially. But that left atrium has a high pressure and its compliance is so overwhelmed, and it will continue to receive venous return in diastole that will make its pressure shoot up and will create further gradient during the diastasis phase. So you will get a bumpy diastasis. You'll get filling during what's supposed to be diastasis. And this L lump or L wave is better seen in bradycardic patient, and it's considered definitely abnormal when it's over 40 centimeter per second. The LA pressure and LA compliance are so overwhelmed that the LA keeps needing to empty throughout diastole and prevent a diastasis phase. But it still cannot empty properly. That's why that L wave is of low velocity, because the LV pressure also keeps shooting up. Now I will describe another important parameter that is easy to obtain. It's the isovolumic relaxation time. So people think that in diastolic dysfunction and in systolic dysfunction, isovolumic relaxation time is prolonged. That's not true. In LV dysfunction, the full LV relaxation is prolonged, but not necessarily the isovolumic relaxation, because the isovolumic relaxation depends on the LA-LV intersection. So in this patient here with high LA pressure, the full LV relaxation is from the top of the LV all the way to that diastolic dip here. However, the isovolumic relaxation is from the closure of the aortic valve until this LA-LV intersection, at which point the mitral valve will open. So the higher your LA pressure between here to here, the shorter your isovolumic relaxation time. So this patient here with compensated diastolic dysfunction may have a prolonged isovolumic relaxation time. This patient with decompensated dysfunction and high LA pressure will have a short isovolumic relaxation time, as the LA pressure will force the opening of the mitral valve early on during LV relaxation. So distinguish LV relaxation from isovolumic LV relaxation. And the higher your LA pressure, the shorter your isovolumic relaxation time. So isovolumic relaxation time is a good correlate of the LA pressure. It may be prolonged in pure compensated diastolic dysfunction, but more importantly, it is shortened in high LA pressure, and it's typically shorter than 70 milliseconds. And how do we measure it? It's best to measure it either in the apical 5 or apical 3 chamber view. And what you do, you put a continuous wave cursor in between the mitral valve and the aortic valve, kind of almost in the aortic mitral interannular curtain. You put the cursor there, and you get at the same time the mitral inflow and the aortic valve flow. And the distance between the end of the aortic valve flow and E wave is the isovolumic relaxation time, as you may see here and here. We should try to do that routinely. We used to measure it by annular tissue Doppler as the distance between S prime and E prime, this here, or this here between the end of S prime and the beginning of E prime, but this has fallen out of favor and it may be less accurate than this technique. Now, I want to explain the pulmonary veins, but in order to understand pulmonary veins, I think you need to understand the LA pressure waveforms and understand the correlation. So this is an LA pressure. You have AX, VY, okay? And this is a pulmonary vein Doppler waveform. So S velocity corresponds to the X descent, S equal X. If you want to memorize it like sex, S equal X, you have to memorize it. D corresponds to Y, whereas the A reversal corresponds to the atrial contraction, okay? So S and D, which are forward flows, correspond to the X and Y descent, to that reduction in LA pressure that creates sucking of flow into the LA, whereas the atrial contraction creates reversal of flow in the pulmonary vein. Of note, normally S wave may be divided into S1 and S2, the same way X descent may be divided into X1 and X2 by that C bump here, which corresponds to closure of the mitral valve and isovolumic contraction point. And typically in younger individuals, less than 40, S is a little lower than D. Those patients have very pronounced LV recall, and they get a pronounced Y descent from the LV recall, so they get a D bigger than S. Whereas as you get older, you get less LV recall, so S may become bigger than D, especially that in older individuals, you get a further rise in LA pressure with atrial contraction. So they get slightly deeper X compared to Y and slightly higher S than D, still within the normal range. And this is an image of a pulmonary vein flow. It's difficult to acquire the pulmonary vein flow. It takes extra skills. And in order to obtain it, it's typically obtained in a 4-chamber view, typically the right pulmonary veins and either the right upper or right lower pulmonary vein. You need to have an unzoomed view, very well opened LA, even if you have to foreshorten the LV, and you tilt the probe either anteriorly or inferiorly. Now I will describe the pathology of pulmonary veins. And here is what happened in pathology. If you have high left atrial pressure, you get big V wave. Big V wave is the epitome of elevated left atrial pressure, okay? Epitome of decompensated heart failure, systolic or diastolic. People think MR, but most commonly big V wave is heart failure. So you have a high LA pressure, you get a big V wave. So what happens when you have a big V wave? You will lift up the X descent and you will deepen the Y descent. That's often the case. High LA pressure, you have big V wave, flattened X descent that is pulled by the V wave, and deeper Y descent. So how does this translate on the pulmonary vein? You will have a flattened X, meaning flattened S, S being X, and you'll have a deepened Y, therefore a big D wave. And the S to D ratio becomes less than 2/3. That's the cutoff used for abnormality. But the more depressed the S, it could be depressed to 0, the worse it is. In fact, with very pronounced V wave and decompensated heart failure, you will have what we call S reversal. So that big V wave will cause a reversal of flow during ventricular systole. Okay, so you can have S reversal. And this is an illustration of that. So the blunted X causes S attenuation, whereas the deep Y causes D exaggeration. Now, keep in mind, you can have those findings also in decompensated mitral regurgitation, decompensated severe mitral regurgitation. What is more specific for severe mitral regurgitation is full-blown S reversal. But you may have in severe mitral regurgitation just S blunting or partial S reversal. But in that case, it's less specific. It could be MR or heart failure. However, you know, if you have MR of moderate to severe severity and S blunting, even if it's not fully reversed, that's likely severe MR. Now, regarding pulmonary vein, there is another parameter that we look at if you acquire pulmonary veins. And that's why it's so important if you're a good echocardiographer to train into obtaining pulmonary vein flow. So the other parameter we look at is the A reversal. And why is A reversal important? All the parameters I've discussed correlate with LA pressure. A reversal correlates with LVEDP. Now, in decompensated heart failure, LVEDP and LA pressure track each other. They are both elevated. But you have a proportion of patients who have compensated LV dysfunction and who will have an elevated LVDP yet normal LA pressure. There is such a stage of elevated LVDP but normal LA pressure. And this parameter, pulmonary vein A reversal, correlate with elevated LVDP. Of course, if you have also high LA pressure, it will be abnormal as well, typically. Now, what is abnormal pulmonary vein A reversal? It is abnormal when it is large in height, more than 35 centimeters per second, or when it is prolonged, more prolonged than the mitral A wave by 30 milliseconds. And how do we explain that? What happens if you have a high LV and diastolic pressure? That rising LV and diastolic pressure will interrupt the LV filling during the atrial contraction. Therefore, it will interrupt the mitral inflow A duration, and it will create more retrograde A flow into the pulmonary vein. So it will shorten LV filling during atrial contraction, and it will shrink it. And at the same time, it will increase the pulmonary vein A reversal amplitude and duration. And they are very easy to calculate, the amplitude as well as the duration. You just measure the difference in duration between this and that. And there is one more parameter that correlates purely with LVDP. It's the B bump on M mode of the mitral valve. We do M mode of the mitral valve in the parasternal long axis view, and typically we have, during diastole, we have E wave on that M mode and we have A wave, and they are separated by this EF slope. For example, in mitral stenosis, that EF slope is flattened. It becomes like this, as there is no diastasis. This is the diastasis here between E and A. Now, normally, you have atrial contraction that opens the mitral leaflets more widely and create that A wave, which eventually ends at the level of the C point, which corresponds to closure of the mitral valve. However, when you have a high LVEDP, that high LVEDP will interrupt the atrial emptying into the LV the same way it interrupts the A wave on the mitral inflow, and it will create a reverse motion of those mitral leaflet in end diastole, which is what we call the B bump. This is an illustration of a case of restrictive cardiomyopathy Okay, so grade 3 diastolic dysfunction. This is a patient who had a low lateral E prime, 6 centimeter per second, instead of 7 centimeter per second. He had a very high E velocity with an E to A ratio of 3, E to A velocity ratio of 3, along with an L lump that you see it here, an elevated L lump, almost 50 centimeters per second, okay? And beside that, you had a sharp, fast E deceleration time, less than 160 milliseconds. Okay, so the mitral inflow by itself was very helpful in this patient in isolation, even without looking at other features. Plus, you calculate E to E prime. The lateral E to E prime was very high here, 23, okay, way over 13, the cutoff for lateral E to E prime. And on the pulmonary vein, you had S&D reversed ratio less than 2/3. You had large A reversal and a prolonged A reversal as well. This was the pulmonary vein A duration was 157 millisecond, whereas the mitral valve A duration was 95. So make the math, it's definitely way more than 30 milliseconds. Another important modern diastolic parameter is LA reservoir strain, which is available on most softwares nowadays. The same way we can apply strain to the LV myocardium, we can apply it to the LA myocardium. But before that, I want to explain what is myocardial strain. I see a lot of fellows not knowing that. They know that we apply strain analysis of the LV myocardium and we get those nice bullseye images, and we measure LV global longitudinal strain. If it is minus 18% or less, meaning minus 20%, minus 22%, it's normal. We can also assess segmental strain, abnormality at a segmental level. Instead of being red, it's blue, meaning it's more than minus 18% at that level. That myocardium is abnormal at this level. But what is exactly strain? You need to know the definition. Myocardial strain is actually myocardial deformation. It's the percent of change in distance between 2 points of the myocardium, between systole and diastole. So imagine 2 points in the myocardium, this point and that. Imagine their distance in diastole and imagine their distance in systole. This is longitudinal assessment. So in systole, that distance will shrink. Therefore, the distance between those 2 points in systole is less than that distance in diastole. And strain is that distance in systole minus the distance in diastole divided by the distance in diastole. That's why longitudinal LV strain is a negative value, because the distance between those 2 points longitudinally is shorter in systole than in diastole. And the normal is minus 18% and less, depending on the software. And keep in mind that the LV myocardium has 3 types of motion. We're assessing here longitudinal strain. There is also radial strain and torsional twisting strain. We can measure radial strain, although it's less reliably measured by current software, and this is measured in short axis cuts. And keep in mind that radial strain will be a positive value because the myocardium thickens in systole from a radial standpoint. So the distance between 2 points in systole will increase if you take it on a short axis cut in a radial level. And let me go back to longitudinal strain. One idea that arises here is that normally you have a negative strain, minus 18% or less. But let's say that segment is dyskinetic, meaning that segment in systole is moving outward. It's actually expanding in systole rather than shrinking. Those are cases where you get a segmental strain that is positive instead of negative. Imagine that segment is akinetic. The strain at this segment will be 0. Imagine it being hypokinetic. The strain will be negative, but less negative than normal. So now that we understood myocardial strain in general at the LV level, let me go back to the LA reservoir strain. So LA reservoir strain is a strain applied to the LA myocardium, and it corresponds to the LA strain during ventricular systole, as the LA is accepting venous return and as it is typically expanding. So LA reservoir strain is expansion of the LA, and it should be a positive value, and it's typically a positive value more than plus 18%. And what does LA reservoir strain correspond to exactly? It really corresponds to how accommodating is the LA compliance. So if you have somebody with a compliant LA, his LA will accept that venous return and will expand to accept that venous return and keep the LA pressure normal. If the LA compliance is overwhelmed, it means that that LA cannot expand furthermore, and therefore any volume that comes in will cause a rise in LA pressure as the LA cannot expand to accommodate it. Therefore, that LA reservoir strain, which corresponds to LA expansion, actually corresponds to LA pressure. If the LA expansion is overwhelmed, the LA pressure will shoot up. So a low LA reservoir strain implies that the LA pressure will shoot up with any venous return. That's why that LA reservoir strain is really a direct correlate of overwhelmed LA compliance and therefore a direct correlate of LA pressure rise as the LA cannot expand furthermore. Like I explained earlier that E to E prime correlates with LA pressure, LA reservoir strain correlates with that as well. And we measure it in two views, typically in the 4-chamber view and the 2-chamber views. Another important diastolic parameter is the pulmonic regurgitation and diastolic velocity. We obtain that on the aortic short axis view, and we place a continuous wave cursor across the pulmonic valve, and we try to get pulmonic regurgitation envelope. Now, the pulmonic regurgitation and diastolic velocity square will correspond to PA diastolic pressure minus RV diastolic pressure. Therefore, that end diastolic velocity really correlates with PA diastolic pressure. PA diastolic pressure is actually that velocity squared plus RV and diastolic pressure, which is nearly equal to the RA pressure that we can obtain via the IVC or better yet via JVP physical exam. So if that velocity in end diastole here is 2 meters per second, that means the PA diastolic pressure is 16 millimeter of mercury plus RA pressure, meaning it's at least 16 millimeter of mercury. And keep in mind that PA diastolic pressure is approximately equal to LA pressure and up to 5 millimeter higher than that LA pressure unless there is precapillary pH. In that case, PA diastolic pressure could be much higher than LA pressure and no longer correlates with LA pressure. But measuring PA pressure in most cases is a nice correlate of that LA pressure, except in precapillary pH, where also TR velocity and PA systolic pressure no longer reflect LA pressure, they reflect the primary pulmonary vascular disease. Now, what are the pitfalls of that? Why don't we do it more often? The problem is that the velocity in end diastole and the pressure numbers are relatively low. For example, the velocity here is usually 1.5 to 2, and the PA diastolic pressure is elevated when it's 16 and above. Those are small numbers, which means if you don't have a good envelope and you mismeasure that number, any small error in measurement will translate relatively into a big error in that number. So you can go easily on that number from 12 to 18 with a slight mismeasurement of that velocity. Conversely, when we talk about TR velocity, it's a larger number and the PA pressure in systole is a larger number. Therefore, a slight 0.1, 0.3 meter per second, error in measurement will not translate into a misdiagnosis. Another note regarding the PR waveform, we can also use it to calculate mean PA pressure, particularly in cases where we're not able to get systolic PA pressure from TR velocity. We can calculate mean PA pressure using the early peak PR velocity. The square of that early peak PR velocity corresponds to mean PA pressure approximately, because mean PA pressure is approximately the PA pressure at that PA dichrotic notch in early diastole. But this is not always very accurate. Now I want to move on and describe how to assess LA pressure in two special entities, atrial fibrillation and MAC. In atrial fibrillation, you need to know that both E and E prime increase in order to compensate for the loss of atrial kick and the loss of A and A prime. But E prime rises more than E. That elastic recoil rises more than E. Therefore, for the same LA pressure, E to E prime ratio is lower in AFib than in sinus rhythm, again, because that E prime rises excessively. Therefore, in order to assess LA pressure, we use a lower E to E prime cutoff. So we can still use E to E prime ratio, but we use a cutoff of 11 instead of 15 for the medial E to E prime in AFib. Also in AFib, we can use the standard parameters of TR velocity, S&D ratio, and LA reservoir strain. And a well-validated parameter in AFib, as suggested by the guidelines, is a low deceleration time or a low isovolumic relaxation time. And you can average those over several, typically 5 cardiac cycles. The same case for E and E prime. And try to assess E to E prime ratio using nearly similar R to R cardiac cycle length for E and E prime. The other situation I want to detail is mitral annular calcification. Like I explained earlier, in MAC, diastolic function is inherently impaired in most patients, as MAC shares the same risk factors as diastolic dysfunction. So inherently in those patients, the true E prime will be low. The problem is that E prime that we measure by Doppler does not reflect the true E prime. Even though it's low, it doesn't reflect the exact number of the annular recoil because of the MAC attenuation. So therefore, MAC precludes the accurate measurement and use of E to E prime to assess LA pressure. So in MAC, in order to assess LA pressure, it's best to use E to A ratio, and a ratio less than 0.8 is considered normal, and a ratio over 1.8 is considered high. We use 1.8 in MAC instead of 2 as validated in MAC. You may also use IVRT, which is well validated in MAC. Less than 80 milliseconds corresponds to high LA pressure. So those two are best validated in MAC, E to A ratio and isovolumic relaxation time. Now I want to move to another point, diastolic stress testing. So I mentioned if you have two variables, you have diastolic dysfunction with normal or equivocal LA pressure. If the patient has dyspnea, we need to do diastolic echo stress testing. How do we do that? We can typically use a treadmill stress testing, and we image the patient 1 to 2 minutes in recovery. Unlike with invasive diastolic stress testing, where we do supine cycling and we measure wedge pressure and PA pressure at peak exercise, and unlike exercise stress echo, where we're looking for ischemia and where we like to image the patient at peak exercise, with diastolic echo stress testing, we typically image the patient 1 to 2 minutes in recovery. We don't like to image the patient at peak stress anyway, because at peak stress, when the patient is very tachycardic, E and A are fused, and you cannot accurately measure E velocity to use it into the E to E prime ratio calculation. So we typically image at 1 to 2 minutes of recovery at a heart rate of around 100. Even if imaging is possible at peak exercise, Mitral E and E prime velocities are assessed once E and A are no longer fused. And keep in mind that when elevated with exercise, filling pressures will remain so for several minutes in recovery. And how do we define elevated LA pressure with exercise and a positive diastolic stress testing? This is defined as exertional E to E prime ratio of 15 or more at the septal level, or 14 or more for the average E to E prime, or a TR velocity of over 3.2 meter per second. We use a higher TR velocity cutoff of 3.2 meters per second instead of 2.8 meters per second at rest, because during exercise, PA pressure may normally rise to 50-55 millimeter of mercury. It's a flow-mediated PA pressure rise, particularly in patients over the age of 50, where their PA pressure reaches 50-55 millimeter of mercury with peak exercise. This is again my summary take on the 2025 ASE guidelines, the three most important features and all the other features listed here. A combo of two variables implies diastolic dysfunction or systolic heart failure with normal or equivocal LA pressure, such as a grade 1 diastolic filling. A combo of three variables implies diastolic dysfunction or systolic heart failure with elevated LA pressure, grade 2 if E to A is less than 2, or grade 3 if E to A ratio is more than 2. Now, this is a more detailed summary of those 2025 ASE guidelines. This one is a little more complex, but is more faithful to those guidelines. And those guidelines like to start with an E prime. If you have a low E prime with an E to A ratio less than 0.8 and a normal E to E prime and PA pressure, you have a grade 1 diastolic dysfunction with a normal left atrial pressure. If you have low E prime with only one variable, again, diastolic dysfunction with normal or equivocal LA pressure. Low E prime plus 2 of any of those variables, then you have elevated LA pressure. Alternatively, if E prime is normal, then you can use a double or triple combination of all the other variables to decide diastolic dysfunction or diastolic dysfunction with elevated LA pressure.